This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of post-op care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today, slightly delayed due to the hectic schedule this week, but today we're going to look at EMDR therapy, so eye movement desensitization and reprocessing. So EMDR therapy has emerged as one of the most evidence-based and effective psychological therapies for treating trauma, post-traumatic stress disorder or PTSD, anxiety, and a range of other distressing psychological conditions. Yet, despite its growing use within clinical practice, many healthcare professionals and patients remain uncertain about how it actually works. So in this compilation episode, we're joined by Dr Abigail Pamich, who is a clinical psychologist with over 20 years of experience. She's also an experienced EMDR practitioner. She is with us and joined us previously on the podcast to explore the science, theory and practical application of this fascinating therapeutic approach. So we begin by unpacking what EMDR therapy is, how it was developed and why it's become an increasingly important component of modern trauma-informed care. So Abigail explains the underlying principles of EMDR, including the role of bilateral stimulation and adaptive information processing or AIP models, before guiding us through what patients can expect during treatment. So we also discuss how EMDR helps individuals process traumatic memories that may have become stuck and allow them to become integrated into healthier, less stressful and distressing ways. So Abigail also walks us through her own journey with EMDR therapy, what initially drew her to the approach, how her clinical experience has shaped her understanding of trauma recovery. We also examine the growing empirical evidence supporting EMDR therapy, discussing where the research is the strongest and also the conditions for which it's currently recommended, and some of the ongoing debates within the literature about EMDR. So throughout this episode, we compare EMDR therapy to other established therapeutic and talking therapies like cognitive behavioral therapy and trauma-focused talking therapies, highlighting where EMDR may differ and offer unique advantages, and where it's best considered as part of a broader patient-centered treatment strategy. So yeah, please do enjoy. We'll see you again on Monday. This is a fascinating deep dive into EMDR therapy. I haven't got lived experience of receiving EMDR therapy myself, but Abigail certainly does. And it's fantastic just to walk through it with her. There is a growing empirical evidence base supporting EMDR therapy as an effective and efficacious tool for treating PTSD. And it was really informative just speaking with Abigail on the components of EMDR. Okay, I do hope you enjoy. Please feel free to rate, review, and indeed subscribe to the podcast. We'll see you again next Monday, and take care for now.
What we do is what's called a formulation. Now, as a psychologist, a formulation is we will create this document, this written sort of document with tables and arrows and how it all connects together. And we'll be looking what's happening in your body, what's happening in your emotions, what's happening in your mind, what's happening in your behavior. How do they reinforce each other? How's this perpetuating the problem? What patterns are you stuck in with that? And we go right back to childhood and we think about how these interact with each other, because fundamentally we're often stuck in patterns, perpetuating downward negative patterns that we can't see. And that's the difference. What we do with talking is we hear everything that's being said, and then we collate it, and then we feed it back within a framework of psychology that we understand. We think about attachment, we think about trauma, we think about early influences. And this is put it into a document that the person can then see developing. And often they go, that's my life. I wouldn't have known that if I just talked about it. It's like, well, no, we do this formulation, and that's what we want to get. We want to teach clients. And then once you've developed this formulation, we create exits. Okay, when you're stuck in this pattern, when you're spiraling and you're abusing yourself and you're drinking too much, how can we intervene? How can we create another side of your mind that will go, hey, stop, wake up? And that's when we bring techniques in. We have particular techniques of stopping and asking myself, what am I feeling? What am I doing? So psychology is all about, we hear the talking and then we create an intervention on top of that, validating and reflecting back. You can't just sit there and go, yeah, I understand, because actually fundamentally we don't. And people don't expect us to understand everything they're going through because we're different, but they want to be heard. And for some people, they're being bullied. They're not heard. They're not, their position isn't given value. And if we don't give somebody value in their position, they don't feel value in who they are. And then that can go through to how they let people treat them in relationships. And I mean, there's so many patterns that people get stuck in. And a big part of therapy is something called compassion focused therapy, which is just awesome and probably for another podcast. But it's fundamentally about how do we regulate our emotional system? And do we regulate it through bullying? Are we attacking ourselves? Or do we regulate it through doing? We do so much that we don't have time to think. Or do we regulate it through soothing? So we bring this whole perspective on and say, well, actually, it sounds like you're regulating your threat system with your drive system and you're burning out. You're going from threat to work, and you're just exhausted. What's stopping you soothe? And then that goes back to childhood, that maybe they weren't soothed, or soothing was being ridiculed. And there's a whole new language for them to learn about how to be calm and kind to themselves. And I mean, it's just profound. Some of these things, I mean, just when I present these formulations back, there's often tears. People are just overwhelmed when they see their life and how it's developed. But also because there's exits as well. Hopefully it's tears of joy sometimes, I'm not sure, but it's so powerful. It's so much more than talking. Yes, yeah.
So Abigail, let's just go straight to the heart of the subject, if that's okay. Could you just unpack for us what is exactly EMDR therapy?
Well, yeah, I mean, this follows on really well, because EMDR therapy just blows out the water anything to do with the traditional sitting and talking, because it's extremely structured. Like as a therapist, I'm imposing a very strict structure on what happens in sessions, and this free flow talking doesn't happen anymore. And it's changing people's lives. It's phenomenal, but it's so different to anything that I ever learned in my doctorate. So first of all, I'll tell you what EMDR stands for. It stands for eye movement desensitization and processing, which is why we don't say it, because it's just such a mouthful and it's so really confusing. In a nutshell, we are working through a structure of something called bilateral stimulation, which is stimulating both sides of the body, back and forward, back and forward, back and forward. So say it's not talking, it's a very physical therapy. So while the client thinks of a memory that's upsetting, we do this BLS, this bilateral stimulation. So this could be tapping back and forward, their hands. Their eye movements could be going side to side, following a ball, or they could have sounds in different ears. And while they're doing this, something happens in the body that starts to take away the pain of the memory. So it's designed originally for trauma, but it's now used in so many areas where something, we'll talk about this more later, but we have big traumas and little traumas where there's something that is holding people back. Interview fears, phobias, public speaking, recovery from abusive relationships, something holding people back. And we can use this bilateral stimulation, this EMDR, to just see incredible change.
Abigail, could you maybe just unpack why you came to using EMDR therapy in your practice? Because I'm aware there is quite a lot of empirical evidence for EMDR therapy, but how did you arrive to it in your practice?
Well, it wasn't really talked about on my doctorate in the early 2000s. It came around, I'll explain a little more later on, but it came around in sort of the late 1980s, but it's really taken hold more recently, definitely in the last 5 years. So I was frustrated with traditional trauma treatment. I'll explain a bit more why later on. But I investigated EMDR, and you know what, it just sounded too good to be true. I mean, it might be like some of your listeners are thinking, what a load of rubbish, you just tap your arms around, you feel better. No, and that's kind of how I felt when I went into it. I was like, oh, come on, I've done my doctorate, I'm working, I'm an intelligent woman. Don't give me this tapping on the table. finish. So I went to the trainings a few years ago now in Birmingham. Luckily, it was face-to-face then. And I was sitting through thinking, okay, well, I've a lot of good things about this, a lot of evidence. I'll just work with it. And then I had my own experience of it. And I was like, wow, no, it melts anxiety away so easily, you can't almost believe it. It's just like, no, how can this be? And I started using my clients. And I have clients come to me when I think traditionally I would have been like, 2 years weekly in therapy, now 10 sessions, and they move forward. And it's like, this is incredible. And I love it because it's just so much less upsetting than traditional trauma treatment, which I think used to just put people off because it was just really harrowing. I have a lot of people that come to me, they've had counselling, and they said, well, yeah, it was nice to talk about it. I felt a bit better for a while, but I'm still waking up at night. I'm still having flashbacks. I'm still feeling terrible. And they don't want to go through traditional treatment. Traditional trauma treatment, they talk in detail about the trauma, moment by moment, as if it's happening. I'm in the car, I'm heading towards the wall, I'm hearing the explosions. I mean, how awful would that be? And then they have to record themselves saying that, and then they need to listen to it 3 times a week. And it does work. It really, you habituate, you expose yourself, and it does work. But I can imagine if it was me and I was really struggling with the trauma, I would find it very hard to move into it completely. So the difference with this is people, yes, they do have to go into the trauma, but it's a very, very small time, very moment, and then you move straight on. And it's processed. So you go into it, and we do the bilateral stimulation, which takes away the pain. It processes it, softens it, reduces it. And really quickly, where with the traditional CBT, it doesn't do that. You have to expose over and over. So I just think it's accessible. And I just hope people listen to this. You don't have to have, we'll talk later, you don't have to have a big trauma, but something that's happened they can't get past. That this is a therapy that is accessible for you. And even remotely online now, there's brilliant software. I work with people all over the world doing EMDR remotely, and COVID has just exploded that and made it really, really, it showed us it works really well. But I just hope people can know about it and come forward, because I think it can change their life.
Absolutely. So you said it is life-changing, and I've seen the evidence in a few colleagues actually how life-changing it is, and that was probably the instrumental sort of reason why I came and wanted to talk about it on the podcast, because I've seen how powerful it can be. So Abigail, just looking at EMDR therapy, when was it developed or first used? Because it does look like it's quite a new therapy tool in the toolbox.
It was actually in the 1980s, a lady called Francine Shapiro. She sort of understood from her own experience that you could process memories by moving the eyes back and forward. And she developed this and researched this and was like, wow, this works. And other people were like, yeah, wow, this works. So she reshaped how we understand trauma, and that we can process early disturbing events to the point where they're not disturbing anymore. So it's not that new, to be honest. I say, if you think about the 1980s, and that's when the research began, it's not like it's been around just for 5 years. It's just become, in the UK particularly, much more, 5 to 10 years, much more well known. When I was working in the NHS a few years ago, I was begging them to get trained, and they were like, there's no funding. But I've now heard that the team that I was in, because I'm full-time private practice now, they've trained up about 10 staff in it. So it's trickling through. But you have to be really unwell to get EMDR in the NHS. I think real, full-on PTSD. Well, I know in my area anyway, diagnosis, which is a shame, because I think a lot of people who don't meet that criteria could benefit from it as well. And also with COVID now, you can do it remotely, the software. And I have to say, Owen, I prefer doing it remotely to in the room, face-to-face, because I can do the bilateral stimulation more intensely when someone's on computer. You can get the ball moving, you can get the coloured balls, you can get the sound in the ears. I wouldn't normally do all those things when I was face-to-face with somebody. So I think I see more powerful effects with people doing remotely, and they feel safe because they're at home in their own room as well. So they don't have to go out to a therapist office and then travel back.
I'm going to ask you just a question, Abigail, around some of the maybe the physiology and anatomy, about just not too deep, but just really what's going on, because and I know it's a side swipe question, but we've got the two hemispheres, the right and the left. The left hemisphere is more the here and now, is the grabbing, is the pinching, is the pulling. The right hemisphere is more the larger picture, maybe where we're starting to think about larger inferences and metaphor, whereas the left is very much the autonomic here and now, and maybe more deeply rooted into the subconscious things you don't have to think purposely about. You mentioned this bilateral stimulation. There's clearly something going on when people are recalling a memory, maybe from their right hemisphere, and also initiating their left hemisphere. So they're tapping, they're moving their eyes, they're listening for sounds. So you're activating left hemispheric preferences, which are here and now, but then you're recalling right hemispheric memories, deep-rooted memories. And in my mind, there's some activation between the hemispheres happening here. Could you maybe speak to that, if that indeed is possible?
Yeah, well, I think what it sounds like you're touching on is the theory of adaptive information processing, which is one of the core theories in EMDR. The idea is that the trauma is kind of encoded in a capsule. So you've got normal memory. Think about what you had for breakfast, say. A normal memory, it's just like, well, I remember eating my food, I remember doing this, but we don't always encode the emotions with it. Now, when we have a trauma, everything gets encoded in this like little capsule. So it's like the fear, the emotional state, the beliefs held at the time, everything gets captured. It gets encoded in this capsule. And then when something triggers out, all these original feelings and thoughts, emotions, behavior, they all come back. But we understand that it's kind of stuck. This capsule is sealed and there's no new information in there. So the information that I am safe now, I'm no longer going to get blown up, or I'm no longer in a car accident, or I'm no longer going to get bullied, I'm safe. It's not getting access. This trauma sort of closed up. And when we do the adaptive information process, what we're basically inserting adaptive information into that capsule, new information, I'm safe. And somehow, like you said, the bilateral stimulation opens up the capsule and allows that new information, that rational thinking, that sort of higher level executive functioning to say, I'm okay, I'm safe, it's all over. And we're inserting that into the trauma memory. And the interesting thing is we don't exactly know why. We really don't. And I love your theory about putting the two together. And it could be that, but all we know is somehow when we do that, when we do the bilateral stimulation, we're accessing this capsule and it's allowing us to put new information in. Some people say, well, it's like the REM sleep. Our eyes flutter backwards and forwards. And that's processing. And that was the original theory, that it's like we're mimicking REM sleep. We're filing away on memories. But there's an EMDR 2.0 in Europe, and they're saying, no, it's not that. What happens is when you open up the capsule, i.e. you think of the trauma, and then you load the working memory really heavily, you get people to name coloured balls and spell things backwards, then the capsule, it doesn't get encoded again properly. You've kind of opened it up. So they say, oh, it's because you're using the working memory. You're weighing that, and then it means it's not encoded again with all the pain there. So I guess we don't, my understanding is there could be more information that I'm aware of today, but my understanding is we don't know exactly how it works. But as you said, yes, it's linking. It's linking the old state of trauma up with the new state and the new thoughts that it's okay, I'm safe, it's all right now. So they've researched it because they're like, surely this can't, surely it's the therapeutic factors. You're being supported, you're being heard, you're being validated. And one piece of research, they actually took out the bilateral stimulation and they didn't get the same effects. So it is the bilateral stimulation that's pivotal. I was having a look recently in the Journal of EMDR Practice and Research in 2019. It did an overview and it said there's more than 44 randomized control trials in PTSD and early trauma, and also in traumatized children. So that's the gold standard of research as well, the randomized controlled trials. It's more than 44. There's also 28 RCTs in depression. They look at bipolar, psychosis, anxiety disorders, obsessive compulsive, substance use disorder, OCD, even pain. It's being this protocol for eliminating pain to suggest that for some people, the pain is a residual capsule of trauma that people are still stuck in. So there's so many emerging protocols, and they're all being researched. It's not like some guy in a lying on a couch is thinking, I'm going to think about a new way of doing this. These are protocols that have been researched and show that it really helps people. People who are stuck in anger, people who are stuck in depression. There's particular ways that we're being taught to use EMDR and process the depression, process it away, process the anger. And it's I think we need it because it is so unusual. I think we need to say to clients, this is real and this works. So I'm really glad the research is there. It helps me fall back on something as well.
Well, actually, just what you were saying there was really interesting, actually, about the capsule concept. And, there's this encapsulated emotions, memories, physical states, beliefs. And when they get triggered, the whole capsule gets triggered.
Everything's triggered. Everything. So if the belief at the time is, I am going to die, say, for example, and then somebody... I've got a few examples we could talk about, but just off the top of my head, say somebody has a car accident and in that moment it's like, I'm going to die, and they feel just utter fear and utter dread and feel sick. Then when they get in a car, again, in the future, if they're traumatized by that previous experience and it hasn't been processed properly, that capsule gets triggered and they have the belief, I'm about to die, even though they're sat there and they're fine. And their higher thinking knows, their executive functioning knows that they're okay. And he looks at them and they think, what's wrong with me? Why am I feeling like I'm about to die? So they come to therapy and they're torn because the bodies and the brain are presenting this experience, I'm about to die. Their high level thinking is like, what's wrong with me? I must be going mad. And of course, there's other things then to work with in therapy. That whole capsule just gets activated as if it's happening in the here and now. And that's what we want to process away. We want to update that capsule. That's a fundamental part of it.
So, Abigail, does a trauma have to be really severe to be addressed by EMDR therapy? And maybe could you sort of categorize what you see on a daily basis from clients when you're addressing trauma?
Sure, of course. Well, I think what's great about EMDR is it's developed. It used to be just called what we call big T's, big traumas, car accident, combat, being attacked, really childhood abuse, events that just trigger what we call PTSD, post-traumatic stress disorder. Now, to meet a diagnosis of PTSD, you need to be stuck in that place of utter fear, as if it's still happening. You have intrusive thoughts and you have nightmares and the body's hypervigilant on edge. So we've got these big T's, these major events. And when people come with that, they know what's caused it. They can remember it. They can't escape it. But EMDR has developed to thinking about little T's. And this is the bit that I love in private practice. So little T's are things that pretty much we've all had. It's the bullying in school. It's the abusive relationship. It's an interview that went badly. It's even maybe a comment from a parent, oh, you'll never amount to anything. You laughed at when doing a presentation. It's these life events that hurt, but they're not absolutely, it's not like we think, oh my goodness, I've got PTSD from it. But we can't move forward from it. They keep us stuck. And then when something triggers that fear, triggers that experience again, that capsule opens up for us. But the capsule isn't there all the time. That's the difference with PTSD. It's like they're in it all the time. But these small capsules awaken when something gets triggered.
So could you maybe speak to a case study where you've seen, it could be anonymized, but a case study where you've seen maybe a certain type of incident which is causing the emotions, the capsule to be activated, mm-hmm. and how you've maybe dealt with that?
Yeah, it's always great, isn't it, to talk about real life situations and real life clients. Before doing this podcast, I did contact a couple just to see how they felt, because people would recognise their story. So everyone I talk about today, it's either hypothetical or it's a story where I have consent to sort of talk about that. And all names have been changed as well. So I'd like to talk about a client. Let's call him Andrew. It's not his real name. Let's call him Andrew, but I think a lot of us can relate to this in different ways. He's got a good job and he wanted to progress, but public speaking was really difficult for him. Any kind of criticism, it just floored him. So yes, we'd say this is a small T. Okay, something's happened that means he just cannot get past it. But actually, it's impacting his career. Andrew is impacting his self-esteem. He doesn't feel like he can reach the potential of where he wants to get to. And that is starting to create depression in him. He feels low. He feels not good enough. He feels like a loser. And he starts beating himself up and having these different thoughts. And he doesn't understand why. Why can't he do these presentations? Why can't he expose himself to other people? What, he knows he's good at his job. What's happening? So from a sort of theory point of view, when he gets a negative comment, his amygdala, which is these sort of threat detectors in the brain, activates. And he says, oh, this is dangerous. A negative comment, this is danger. Now, is the comment itself dangerous? Like, oh, Andrew, you could have done that report a bit better. Well, no, he's probably not going to get the sack. But what's happening is activating a fear state in his body. It's activating that stress response. Now, this is where it's slightly different to just a normal stress response, is he can't talk himself down. He tries his breathing techniques. He's done some CBT. He's doing his thought challenging visualization. None of it works. And this is the difference when I think EMDR is going to work, because people get stuck. Intelligent, rational people get so stuck. And then I say, okay, this isn't anxiety. This is trauma. Because I think when it's trauma, your brain just switches off and you really can't move forward. So somehow, somewhere, Andrew's had an early experience or previous experience of being criticised, and it's unsafe. We could think of this maybe like a persecuting and a shaming teacher. So when he does something wrong, it is unsafe. He feels helpless. He becomes ridiculed, and then he's bullied. And all this is stored in a capsule. So when he gets criticised at school, the same thoughts come up. I'm helpless. I'm going to be bullied. I'm going to be unsafe. And all the same emotions are released, as if he's the child back there as well. So he doesn't have that new information of, I am a man. I am grown up. It's okay. I can take it. That information hasn't been updated in the capsule. All the old one from when he was like 9 is stored. So what we need to do is we need to firstly locate that trauma, process the trauma by bilateral stimulation, and stick the new information inside that he's perfectly capable now and he can manage all of this. And we could do that by the eye movement, or we could do that by the stimulation. So we have the tappers that stimulate both hands or in his ears, but some form of bilateral stimulation means that you can actually get rid of that original trauma, process away the emotions and update it. We always need to just update with the new information. And we can talk more about this later, and hopefully we can come back to him when we talk about the formulations.
Abigail, just what areas is EMDR used in? Is it common within the NHS practice and private practice? What sort of domains do you, or indeed of pathology, what domains of pathology do you use EMDR in?
Well, I guess it's become open to just all kinds of presentations now. It is used a lot more in the NHS, but it's harder to get access. If you think of the waiting list is big enough for the adult mental health primary care service, you then want the EMDR, and there's like 3 therapists that offer that. They all keep it for the worst cases usually. So I think it is accessible, and I would say to give that a go on the NHS, because it's always the first port of call for people, I think, because it's a free service, and there's some fantastically qualified therapies on the NHS. And particularly if you've got the PTSD, the big trauma symptoms, hopefully you should receive EMDR on the NHS for those. They don't tend to do EMDR so much for the smaller Ts. That seems to be more what we see in private practice, where we do have some big Ts because we get insurance clients that come through, and people that don't want to wait as well on the NHS or don't want it on the medical records. But yeah, I mean, all kinds of things, relationship breakdown. I do particular therapy for people recovering from relationships, and part of that is some EMDR, so they don't carry forward the trauma from being hurt in that particular relationship. Abandonment issues, imposter syndrome, bullying, abuse, performance enhancement is a big one. How can we be more successful in our careers? How can we move forward? But you've also got the things like phobias, the depression. There's a particular protocol for depression, anger, pain. I think I said before that anything really when there's a blocking belief and experience, and that can be located. And some EMDR practitioners say you don't even necessarily have to locate the original memory if you can't think of it clearly. It's just a sense of something, then that can be worked. For some people, you can just do the future template and the present triggers. You can have success. For some people, I've just done the future templates and that's worked really well too. Watch this space. It's just growing and it's a fantastic approach.
That's fantastic. So you did actually speak, Abigail, to the fact you've had EMDR therapy yourself personally. So could you maybe just unpack that a little bit more as to how effective it's been? And indeed, just maybe just only as much detail as you're comfortable with, really.
Of course, sure. I think it's always good that as therapists, particularly doctors, we can let people know that we're human and we've had our own things that we've been through as well. When I did my doctorate, we were encouraged to have therapy. So I had therapy weekly for 3 years. So I've had the experience of not sure whether you trust your therapist, not sure whether it's working. I've been through all of that. And a lot of that time it was talking about some of the experiences of my childhood and bullying. And I have to be honest, those 3 years didn't get me as far forward as about 9 sessions of EMDR when I actually processed these early comments of everybody hating you. But I mean, it gave me other things. But I think when it comes to moving forward on something, that was a lot of therapy and I still carried it with me. But I had it with the working through that feeling safe in groups of women, I think was predominantly what the difficulty was. And of course, not feeling safe, one appears a little bit defensive as well. So I think I wasn't always great in groups of women because I felt a bit unsafe. I was maybe a bit grumpy, a bit defensive. So it then impacted on how people related to me as well. But that's gotten a lot better. I'd like to say it just doesn't occur to me now to think that people might hate me. And if they do, it's like, well, I can't do anything about that now. That's just, some people might. That's okay. I don't feel unsafe anymore. That's okay. And I had EMDR more recently, actually. I had, as well as lockdown, I was unfortunate enough to have cancer diagnosis as well, which was on my face. So I had to have some of my face removed and I couldn't smile for about 3 months, which as a therapist was quite worrying because I wondered if I'd ever smile again. And I'm physically completely healed from that now. But emotionally, I feel I'm just scraping the surface of recovery, to be honest. Learning to feel safe in my body. I think for all cancer survivors, that's a huge part. Trying to believe that I have a future. And EMDR, it wasn't about any of the physical treatments, but it was working on that moment of thinking, I haven't got long to live. And that stayed with me, even though the cancer was gone and I was fine and I'm post a year recovery now. There was that legacy of feeling, something might happen today. I might die. Something might happen. And it wasn't necessarily even cancer. I might have a car crash. But that sense that an axe is going to fall on my head at some point because it was there. And EMDR was brilliant for that. I worked through the trauma that thought, I'm unsafe, I'm going to die soon. That was my belief that I was stuck in. And processed that out, and it didn't take too long. And then the new adaptive thought was, I'm safe, I survived. And that tends to be what stays with me now. And again, it just faded away. I just realized that weeks had gone by and I hadn't thought that something was going to happen that day. I just got on with life. And I think it's really big actually for people with big physical diagnoses, because the NHS are great. They heal the body and then you get on. But sometimes the mind stays in that place of, I'm not okay. And that's what I'd like to let people know about EMDR, is that it can help your brain catch up to see that you are okay now and that you can survive. And then that's perfectly normal for your brain to be stuck back there, because, I had that myself and I think it happens to a lot of us.
So Abigail, what would you say to listeners that are maybe struggling with traumatic feelings, and what should they do with them from your perspective?
I think try to understand what's happening, but really from a compassionate watcher perspective. A lot of people think, what's wrong with me? I'm going crazy. I must stop this. And they avoid and they criticize and they put down, and actually creates a cycle of feeling a lot worse. So it's about creating safety within yourself. So I just be kind to yourself, but be inquisitive. So when you have the traumatic feelings or thoughts, get a piece of paper now or afterwards and say, what was I thinking? What were the thoughts? What was the emotions? And just try to get it down. So it creates a little bit of distance. And often it's thoughts, I'm lovable, I'm defective, I'm safe. But if you can just cue into what these are called automatic negative thoughts. And there's automatic negative thought questionnaire, which is on the internet if you're not sure what might be the thoughts, but try and get the thoughts. And then you could go back and think, well, what was the first time I ever thought this? I am unlovable, or had this experience before. And even if it doesn't make sense, that might be the seed, that might be the beginning. And then you could maybe just start having conversations with the people, your support, people in your family about that, and start to bring it into consciousness. And then it could be that that's healing in of itself, or it might be that you want to seek out some EMDR. And there's lots of great EMDR therapies out there, but make sure they've had accredited training. And if they're doing something that seems completely different to what I've suggested today, then it might be worth just checking out what protocol they're using, because this is quite a standard 8 phase. Again, we're not recommended to do therapy and just drop in little bits of EMDR here and there. That's not the advised way. It's supposed to be okay, we're doing EMDR for this session, and it follows a particular protocol. And yeah, if you're not near one, online is brilliant. Pretty much all my caseload is remote at the moment, and we're just having great results. I've got a lovely big team as well. If it's not us or other therapists, just seek out somebody, even if you just give it for maybe 10 sessions and just see where you can get. I think you could really find that that's really helpful, whatever the blocks are that you might be experiencing.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.